Hello, welcome to Humanity and Beyond. I am your host for the day, Tyler James, and I am joined by Evelyne Bischof. She is a geroncologist and longevity physician, so we like to claim in the field, if she doesn't already claim it herself, but she is known affectionately by her colleagues and by her friends as Eva. So I'll be addressing her as such throughout. Eva, you want to just go ahead and give a little bit of background as to, what drove you into the field of longevity, and why you went about the route of cancer study as a bit of an avenue into that.
Mm-hmm. Well, first of all, thank you so much for having me on the podcast, Tyler. It's, as I mentioned several times to you bilaterally, but I would like to just really underline it once again for the audience. I think it's extremely important to have these types of communications and these types of venues where everybody can be informed about the progress or the basics of longevity and the research and whatever is going on in this area, because only by a good and solid education and information we can move the field further. And this does not only concern scientists and physicians, but basically each of us, because many of my colleagues share the opinion that I have, that aging is a disease. And by this definition, each of us, every person on this planet is a patient, right? So we are all suffering from aging. And so thank you so much for having this podcast and for having me on it. And it's a pleasure. And your question is actually extremely interesting and also extremely, let's say, leading already into explanation of longevity. Because how did I get involved? In fact, I'm an internist. I'm an internal medicine specialist, a clinician and academician. And my research focus was in the oncology field. So I was working mostly on biomarkers and early diagnostics, precision diagnostics. And, oncology is definitely one of the disciplines where precision medicine was hitting in very, very rapidly. And so I was working in that field. And when somebody is looking at cancer closely, they can realize two things, both clinically and molecularly. Number one is that the old age is the number one risk factor to develop cancer. And we are forgetting about that very often. We are thinking about genetics, we are thinking about risk factors in lifestyle, and so on and so on. But the number one risk factor for cancer is actually old age. And by this, I mean biological age. We can dive into it later on. And the second thing is that the pathways, the molecular pathways, so what is going on in the cell and actually on the genetic level in our bodies, the pathways are very much interlinked between cancer and aging. So many of those roads are being shared by these two, let's say, conditions. And this is how I got involved in the field. So partially due to my work in oncology and those pathways and how some of the therapies are actually interrelated. So some of the cancer therapies might now be explored in the anti-aging field, see rapamycin. And on the other hand, the precision diagnostics and the thrive and the strive and the wish to move towards really a precision diagnostic way in advance. So not a diagnostics when the cancer is already there or is burgeoning in the body, but more and more into precision diagnostics months, years, or decades in advance, and hopefully soon, pretty much at birth, so that the risks can be mitigated or hopefully also eliminated, so that we do not have cancer at all at the end of the day. And when we have it, then we understand all the pathomechanisms so well and can have tools that allow to develop and synthesize specific targeted medicine for a specific person in that specific moment, so that the cancer can be cured. It's a fascinating field. It sounds a little bit as a science fiction or as a dream of every physician and every patient, but I think we are on the way there, and I think it's realistic, and I think we will get there.
Oh yeah, I have been very aware of what's been going on in the field, just with the research that's being conducted here in my home state. At the University of Utah, we have the Huntsman Cancer Center. They have been doing a lot of research into, the precursors for the diseases. Mario Capecchi, I think the name is. He is one of the primary researchers that we've been having up there, and it's really a very fascinating field. Is there anything specific? I know, COVID being what it is, but is there anything specific that you've been looking into recently, or have you just been sticking more to academic subjects?
Mm-hmm. With COVID happening, my interests and work has definitely intensified and dispersed into different topics around longevity and beyond. I think, with all of the disaster and sorrow that COVID brought to us, there are some positive things. I'm trying to think positive because also now we know that thinking young is actually making you younger. So COVID definitely opened the eyes to all of us about one very important aspect, and the aspect is that aging and the biological age is a very important factor towards being vulnerable to infections, and not only to infections. So I think the impact of aging and the impact of comorbidities, right? So the additional diseases that the patient, I'm always saying patient, that the person has a major impact, and COVID showed us that it can affect our daily life, right? We have been looking at a variety of things. So beyond the research, so I've been involved in some of the consortia that are working specifically of drug repurposing and identification of compounds that would target COVID, the virus SARS-CoV-2 specifically. But I think this is beyond the scope of this podcast, because that is not related to longevity. But one of the things, or two main things that we were looking at in terms of COVID and longevity was, number one, the impact of the biological age as measured by aging clocks towards the vulnerability of A, getting the infection, and B, the outcomes, right? Mm-hmm. So, and the comorbidities are definitely one of a factor that is influencing the biological age. So, simply said, a person like me, who is, I don't want to reveal no, I'm kidding. I'm 35, but my biological age, based on my comorbidities, might be 42, right? It's not, but it could be. For example, if I would also have diabetes, or if I don't sleep enough, which is actually unfortunately the case, my biological age could be higher. Now, we know that after some of the analysis, we know that advanced biological age is actually associated with a poorer outcome of the COVID infection and with higher infection rate with SARS-CoV-2. So what is the impact for the clinic or for the real life? Well, basically not exactly that the physicians should be looking at the passport age of a patient or just to see the diagnosis list of a patient, but to actually maybe run a specific test to assess the biological age, and by that do a better triage or do a better prediction, and also decide upon the treatment, navigation. So this is one of the biggest fields, I would say, and the other one is the use of geroprotectors. I do not want to specifically name any, but geroprotectors for the general audience, or especially people at risk. So again, older people or people with comorbidities, wherever it is, of course, possible, to use geroprotectors for two reasons mainly. Number one is to protect them in general, to get the infection. Number two, to improve their outcomes. And maybe also number three, to augment their response to the vaccine. So it's great that we now have the abundance of vaccines, but those who are at risk in general, they also have a disadvantage in terms of the potential of the protective potential of the vaccine. So giving them some sort of a booster, giving them some sort of credible geroprotective measure would also better and augment their response to the vaccine and get them more protected. I know it's very complex. I hope this all makes sense. Yeah.
No, and I'm sure that people parse it apart as they need to. Just want to address a couple different things in turn. I mean, to be honest, and this is, point blank my own opinion, you don't look a day over 25, so you don't need to worry about that.
So kind.
No, and I am being honest. I mean, I feel you there with the lack of sleep, with, in the US especially, we are very prone to high sugar, high fat diets. I personally don't really have the time or means to take care of myself. So, even though I am lining up to get the shot for the Moderna vaccine at this point through the county government, I know that there's still a lot that I can do, even though, I'm personally 25 this year. Lord, doesn't even feel like it's been that long.
Oh, enjoy the time. Mm-hmm. Yes.
Oh, I'm trying. But yeah, I mean, when you're talking about the geroprotectors, it's more than just, the zinc and the vitamin C, right? It's potentially other things that will help combat those comorbidities, right?
Yes.
More generally, or?
Yes. It's actually a very fascinating field because we have so many levels of geroprotective approaches, let's say. And sometimes, I think one of the stigmas that I would like to address and maybe to elaborate on a little bit is that some people might think that longevity medicine is almost just about lifestyle or almost just about, giving some supplements and just thematizing the way of extending lifespan, but not really doing anything in that direction. So I would like to rectify that and really assure that longevity medicine is not about, so it definitely is fueled by functional medicine that is very good in supplements, metabolomics, and so on. it's fueled by precision medicine. It's fueled by internal medicine very, very deeply, because the longevity physician has to be also a very good and solid internist to make a differential diagnosis and to have a very complex algorithm going on in their heads. But longevity medicine at the end of the day is mostly like super fueled by AI and by genetics and by omics and by all the technology advances that are out there. So it's so complex and it's so not well described yet that some people might think, okay, so a longevity physician is basically just gonna give me geroprotector, which means like vitamin C and zinc and selenium. Well, no. To make it simple, like maybe to illustrate it in a simple way. If I have a patient that is coming to me and I make a full anamnesis, I know the post-medical history, I know that the patient, for example, had a cancer in the past, but the patient is now in remission and is leading a relatively unhealthy lifestyle, but would like to optimize the health so that the patient would be a longevity patient. And the goal is to give him a healthy lifespan. We do not aim to prolong his life. Reactive medicine, the standard Western medicine, is already doing that. We are prolonging life in every hospital with every therapy. This is why the palliative medicine is now so well developed. But longevity is not about that. Longevity medicine is about a healthy lifespan. It means prolonging the time of life of a person with the optimal performance. Meaning it's not about the quantity, it's about the quality. And if a person comes to me, I would have to make an extremely descriptive and very, very detailed anamnesis that would not only implement the standard forms that we have and the standard labs that we have, but really precision diagnostics. So we are talking about usually like 15 gigabytes of data with the top precision imaging, with the top precision genomics testing, with the top precision dive into the genome, with the full picture of the metabolomics. And then on a day-to-day basis, I would follow the patient also with the 24 hours tracking of various parameters of his glucose, insulin levels, of his sleep scores, of the oxygenation, of the blood pressure, pulse, hopefully also very soon on the electrolytes and so on. So longevity physician always has to keep a track of the best and credible technologies that would allow basically a continuous monitoring. And it's permanent. Everything is permanently about the data. And the more data I get about the patient, the better I know the patient and the better I can adjust his geroprotective approach. So sorry for the long elaboration, but I think it is important to mention it so that we come to your question, like what is the geroprotective approach? It's not only vitamin C. It might include vitamin C. It might include many vitamins, because at the end of the day, I will know what kind of vitamin deficiency my patient has at a specific moment. And geroprotection also means, of course, lifestyle intervention. So, for example, with the continuous glucose monitoring, I can definitely see if my patient would be of a need of intermittent metformin intervention that hopefully soon will be proven in the clinical trials. For example, Professor Barzilai with his TAME trial is, I think, the best example of how metformin can influence our lifespan and longevity and the health. But also other interventions with, supplements that are out there that are in preliminary studies, but that show great potential. So Rapalogs or NAD boosters, and other therapies. I do not want to specifically mention any because unfortunately, what we would like to avoid, and I would truly like to appeal and ask people to not to experiment themselves on those geroprotective treatments. there are information out in the internet, and there are books written about it, and there are anecdotal examples, and we have good and wonderful people who are setting the example and leading the path and experimenting on themselves. However, from the medical perspective, since each and every one of us is so different, and there are so many nuances in our biology, and one could really harm him or herself with such experiments, even just by the wrong dosage, even just by not catching up the right lab parameter and so on. So I would really like to say that we have now good options, but everything should be done under a monitorization of a physician, of a physician that has some knowledge about this field.
Yeah, and I am totally behind you there. Also, what we've been seeing a lot of, and this is just anecdotal, I know it's a little bit of a digression myself, but we have a lot of those multi-level marketing companies, doTERRA, Nature Sunshine, New Ways. Well, they are, New Ways, I think, is still the name of it. But I mean, everybody has the quote unquote pill to solve everything. And it really is sad that it's so difficult for people to understand that everything about medicine is individualistic. Even though we try to get things as general as physically possible, at the end of the day, you need an individual treatment plan because there is only one of you. That is both good and bad. And, and it's an issue that we run into a lot in bioethics as well, is just what can the doctor do to ensure that not only are they treating their patient, but then the patient comes back to them. Because if they're asking for the miracle pill and the doctor gives them a regimen of exercise, supplements, X, Y, and Z, that's not what the patient asked for. And, in some aspects of our society, people want that convenience. They don't want to have to do the extra bit of work, but that's just anecdotal from my own perspective as well.
No, I don't know. Like, I definitely, agree that the personalized approach is mandatory. This is what definitely longevity medicine is about. It's a level up of precision medicine, because precision medicine is still very precise for a specific group of patients. And this group is getting small. But to have an individualized approach for a patient at a specific time. So I'm always, I'm several times I mentioned this during our conversation. It is very important to also understand at a specific time. So we are looking at the person at a specific time, at this moment. And this is how the patient should understand it. The patient's state will not be the same in a week, in a month, or in 5 years. And the longevity medicine is there to help at a specific time to put the patient back, or to put the patient into the optimal frame of their health, being biological age, be it cellular age, whatsoever. And why do we still need a doctor for that? This is a question that is being discussed as well. I think it's a valid question, and that's, I think, another point that is being raised and that I was not aware of, coming from very academic medicine. I was always in the hospital setting. I was never in a private practice or in a private clinic or whatsoever. I never had to deal with any administration or cost and so on. But this thing that the patient should return to a doctor, and that the doctor is basically just trying to get the patient back and so on. I think this might be true for some, but in general, this never should be the issue. The point why the doctor should be following a patient and be involved at least at the beginning of the journey, is to help the patient find the best way to change the life into a germ-protected way of life. Meaning, I have patients who just do not accept and cannot implement and will never probably implement the lifestyle interventions that are proven beneficial for them. They don't have the time. They are busy people. They are tired people. They are people who just cannot and don't want to do it. We know that intermittent fasting is working. We know that sleeping well is very important, and so on. There are people who just cannot implement that in their lifestyle, and that's fine. It's my job as a longevity physician to find a way around it and to make the best out of it, to find tricks, to find ways, to find little things that we can adjust, fitting not only into the patient's biology and physiology, but also into the patient's social and environmental influences, and adjust it as we go, right? And I mean, also the way of supplementing things and fixing things. So, for example, for many patients, we need to fix their sleeping pattern. We need to fix their eating habits. We need to fix their insulin levels. We need to fix also their muscle mass. So for this, we do not need a life. There is not a plan for the whole life. There is a plan for a month. There is a plan for 3 months. And after this would change. So automatically the patient will need to return and to be guided if the patient wishes to really be successful. Otherwise, of course, you can just follow the internet. But, there is this joke that we say, if you went for the first opinion to Google, please refer to Yahoo for the second opinion and not to me, So this is basically the status at the moment.
Mm-hmm. Well, and I guess a question for me then would be, what would be the difference between longevity and preventative medicine? Because the way that you're talking about longevity, a lot of people who are familiar with what the scope of preventative medicine is, what its rationale is, they would basically be saying, well, these are the exact same thing, aren't they? It's just one's more precise, one's less precise.
Awesome. It's an awesome question. It's a very good question. I love this. So, of course, there is a huge and major difference. To explain it easily, I would just say the preventative medicine is one element of longevity medicine. Precision prevention, precision diagnostic for the prevention, and the top technology to prevent diseases is a part of longevity medicine. So, of course, prevention, we have like 3 types of prevention. We have the primary prevention, where we diagnose things or we just screen for things that are hopefully not there yet, or we want to detect them at a very early stage. So longevity medicine uses the top applicances for this type of prevention. And this includes like the 4G Tesla MRI, or the newest algorithms, AI algorithms that have been developed to be added to a normal CT scan. So again, example, in a normal hospital, a patient would come for, a CT scan. No, usually we do not even have that. Let's say mammography for breast cancer prevention, right? It's the usual screen. Or colonoscopy for colon cancer, or PSA for the prostate cancer. Now, in longevity medicine, the prevention element will actually not include only this. It will include algorithms that will be put up on top of the CT scan or on top of the mammography, actually not even mammography, but MRI of the breast. And not only a colonoscopy, actually we are moving away from this, but very precise testing. I don't want to require the intervention, and can detect the colon cancer not when there is already a burgeoning part of it, but at least 1, 2, 3, 5 years in advance. And another thing is that this prevention in longevity medicine is now including and targeting diseases that are not included in the regular prevention. For example, we do not have a plan for prevention of pancreatic cancer, right? But in longevity medicine, with like the yearly screening that is recommended, there is already an algorithm for that, and for many other things like aneurysms in the brain and so on. So let's say prevention medicine is a part of longevity medicine, but the longevity medicine took the prevention medicine on to another level, on a much, much higher level, and it is constantly evolving. So it's so rapid that I could talk about it for hours, but it's just like exponential growth, like a bacteria.
Mm-hmm.
But then longevity medicine also has all the other elements besides of prevention, because it also goes to therapy and so on. So this is the main difference.
Mm-hmm. Yeah, and I so want to delve into that realm with you forever and ever and ever. I am so heavy into the use of AI in medicine, how we sort through bias, how we ensure that, the proper tumors are being detected, and, all that fun stuff. It's just forever and ever and ever. But we do have to limit ourselves. We do have to scope ourselves.
Yes, that's correct.
But I guess another question I would want to pose to you then is whether we have gotten to the point where we have discovered, or at least have a good estimation on the upward limit, if there is one, for how long the human body can last in the proper environment with the proper amount of care.
I'm very reluctant to answer this question because there are just so many opinions, and there have been so many opinions on it for over a decade now. I don't think we have a credible answer about this. I think it is realistic to assume that we can all live to over 100, something around 120 with what we have at the moment. If we could implement for everybody, or for a specific person, all the top developments that are available, if we would be able to do that, that person could live definitely on over 100, 120. If there was no comorbidity already prior to this in advance. So it's very complex. And there's, again, no one size fit all. That's another thing. So this said, I would like to remind everybody that longevity medicine is not only about living longer. Of course, some people would like to live longer in optimal health. And that's the ultimate goal. Having somebody living up to 120 or 200 with optimal health, that's the ultimate goal. We are quite far away from it. But to give a person an optimal health up until a specific age, and this can be very different for everybody. I would be very happy to live with my optimal health up until 80. I do not want to live with frailty until personally. And there are also some people who don't like that. So longevity medicine is really about to give an optimal performance range for the patient. It's not only about extending life.
Mm-hmm. And I only ask that because it's so prevalent in the science fiction media. I mean, you have some people speculating that, well, the brain can last easily for 140 years. There's enough storage capacity, So, and, I have a fair few number of real examples of ancestors of mine who came from Ireland. They made that great trek across the Atlantic, landed in Louisiana, made that great pilgrimage across the plains, and helped to settle Utah with the Mormon pioneers. And we had people living to their hundreds. And, in recent memory, we've had on my mother's side of the family, somebody living well over 100 and, escaping out of the nursing home just to go to the town hall so that she could go dancing again.
Awesome.
So, it is feasible to get to 100. People have been able to do it without all of this longevity research, without all of this, new tech, new science. It's just a matter of making that concerted effort.
Exactly.
And, a question I did have is, even though you and I both know that it is likely not the case, but if there would ever be a future where technology is doing everything for us to ensure that we are living as long as possible, whether that is regulating our diet, making sure we're getting the right amount of foodstuffs in us, making sure we're getting the right amount of supplements, the right amount of water, basically forcing our bodies to exercise so that we're maintaining our muscle mass. Do you see that as, something that is actually a feasibility, or is that just so far from the norm that only the most eccentric are going to be able to even get a fraction of that?
I think we have truly amazing passionate in that field that are striving towards, let's say, democratizing the longevity field. And I believe for quite a while, there will be a moment where only those who can get the access to the top developments will be able to really take a benefit of it. But looking at, for example, even the development of the genetic testings, right? Decades, not even decades, like years ago, it was quite an expensive thing. Right now, you can have a test for a very low price, and I'm hopeful that this will be the same for further developments in the longevity field, including the technologies that will be there for us to do the precision medicine and precision therapy at home for everybody at any point of time. This said, of course, there will be levels, and there will be, there will always be some kind of a market thing that you will probably have to, be somewhere in the range if you want to have the most advanced treatment, or how, this will always be the case. But that's already not connected to medicine. That's already how the world is going. But I think for the basic things, I hope that very soon everybody will have the access, and it will be feasible, and it will be accessible. And the more people will understand it and use it, the faster probably it will happen that all those approaches and all those to people, to people of all levels, not only those of So that's maybe just to summarize a final sentence. I believe that longevity medicine is actually one of those fields that can bring a little back the balance towards health equity and equality, which are not the same things, right? So I'm very much deeply convinced that this field is actually, if nicely conducted and with a good collaborative spirit, this can actually be very much helpful to balance the access to health and impact positively the health equity.
Mm-hmm. Well, I'm keeping on time here. I don't want to overstay my welcome. I know that we can talk for hours on this, and I honestly wish I was just there having a cup of coffee, just enjoying, the pre-COVID relationships that we had. But
like different world, huh?
I know, right? Well, we're getting there slowly. It's never going to be exactly the way it was. There's always going to be some residual that we're going to be seeing for COVID. And that's the truth with any pandemic, any plague, if you have it. I mean, we still have carryovers from the Spanish flu, for crying out loud. But I guess I should ask if there is anything else that we haven't really covered that you really wanted to get off your chest to, basically help level that field of hype and, bring a bit more reality into people's, periphery.
Maybe one thing. I strongly believe that being well informed is the key here. And very often physicians and scientists, they cannot really get their voice out there against maybe, a lot of marketing materials and so on. So one thing that I would like to point out is, that I would like to motivate people to do is really to get informed or based on credible sources. So I don't want to make a promotion here of anything, but there is the first longevity medicine course for physicians, but it's not only for physicians, and it's for free, and it's made by the leaders of the field in a credible way. So if you Google that on longevitydegree.com or on Udemy, you can find this course. Also, there is academic. Usually, you should look into academic activities that are talking about the longevity. For example, there are wonderful series of webinars by Sergey Young, by Brian Kennedy in Singapore. There is a conference called Aging. Assembling basically the leaders, the key opinion leaders, all the scientists, and now even the physicians to talk about the field. I believe looking onto those resources rather than the super pills advertisements would be very valuable, and again also help us to advance the field, because one of the most important things for us is also to educate the patient and to educate physicians, so that we can move forward into the right direction.
Would you mind repeating the name of that conference one more time? You cut out right as you were saying it.
With a great pleasure. So there is an annual ARDD conference, and you can find it under the website is called agingpharma.org, or if you just Google ARDD conference, so Aging Research Drug Discovery Conference. And this year, for the first time, we will have a specific panel. We will have a full day of longevity medicine, where we will have really the top key opinion leaders speaking there. We'll have Lancet Healthy Longevity journal there being a co-host with myself. We'll have the key opinion leaders, Alex Javorenkov. We'll have Michael Bogoskonny. We will have Daniel. We will have a lot of people. I don't want to put anything in the top light, because if you look at the website and you look at the panelists, all of them are just brilliant. All of them. Each and single person is a brilliant star in the longevity field. And this conference is very special because it is bringing all of them at one virtual and also offline table, because it will be also an offline conference.
Do you know the dates at the top of your head?
Yes. It will be on the longevity medicine will workshop on the pre-day that I would cordially invite you to, as I am the the coordinator of this, is on the 30th of August. And this will be a whole day event, also with pre-recorded lectures, but also with live panels. And then the actual conference will be run from the 31st of August until the 2nd of September.
Well, I'm definitely going to have to get that in my calendar and spread the word, because there are a lot of people who are very interested in this field of study. We have been seeing a lot of, just general AI in health conferences. So it would be really good to connect that longevity research with everything else that's been going on, and try to help get that message a little bit more consistent and a little bit more, out in the open. So with that, I'll go ahead and close off here. This has been Tyler James with Eva here on Humanity and Beyond, and we look forward to catching you on the next episode.
Thank you very much for having me, and all the best and healthy longevity for everybody.